Welcome to PGOG Postgraduate class in Obstetrics and Gynecology, and today's topic is fetal Doppler. For basic understanding of this topic, what we will see is first uterine vasculature, then fetal circulation, and some important points related to the physics behind the fetal Doppler. As we can see here, this is the endometrial layer, and outer one is the myometrial layer, and in the vasculature, uterine artery is sending the perpendicular branches into the myometrium. These perpendicular branches of the uterine artery again are sending the parallel branches parallel to the long axis of the uterus, and these parallel branches form a rich network which are called as the arcuate arteries. Arcuate arteries are again sending the perpendicular branches which are radial. These radial branches are sending the umbilical arteries, which forms again a longitudinal network along the long axis of the uterus, and from these vessels, important spiral arteries are piercing the endometrium, and especially in the luteal phase of the menstrual cycle, these spiral arteries are supplying the endometrium. This is how the spiral forms in a spiral artery. Why we are discussing this spiral arteries? The important event which takes place during pregnancy, it is called as spiral artery remodeling, which takes place in two stages. First is a primary invasion by 12 to 13 weeks, and this invasion, now here this is the spiral artery before invasion, and this is the spiral artery after invasion. So this primary invasion takes place by 12 to 13 weeks, and the cells which are leading to this in primary invasion, these are called as extravillous trophoblast. As we know, in the development of the placenta, we have primary villi, secondary villi, and tertiary villi. Some of the trophoblastic cells remain outside the villus structure, and these are called as extravillous trophoblast. Here, as we can see, the yellow ones, these are extravillous trophoblast, and as trophoblast, we know that it has a tendency to invade. It can invade the surrounding tissues. Similarly, these trophoblastic cells also they lead to the reduction in muscular and elastic content of the vessel wall. So the vessel wall becomes thinner, opening of the spiral artery becomes wider. Another wave of invasion takes place, which usually starts after 15 weeks and gets completed by 24 to 26 weeks of pregnancy, where the myometrial component of the spiral artery, the same vessel, the myometrial part, it is getting similar changes as we have seen in primary invasion, and these two together we form it is called as a spiral artery remodeling. What is placental syndrome is whenever there is an inadequate primary and secondary invasion, it leads to chronic placental insufficiency as a main pathology. So that and with that there is increased risk of fetal growth restriction, hypertension in pregnancy, and stillbirths. And this is known as placental syndrome. In these cases, even post-delivery histopathological examination also shows the changes suggestive of inadequate primary and secondary invasion of the spiral arteries. Spiral arteries are not adequately getting invaded, and abnormal Doppler findings are commonly seen in these cases. In the fetal circulation, the main difference between the fetal circulation and post-delivery newborn circulation is there is a presence of three shunts. Foramen ovale, through which the blood enters from right atrium directly into the left atrium. Ductus venosus, which connects umbilical vein, so that from umbilical vein directly blood goes to the inferior vena cava bypassing the liver. Ductus arteriosus connects pulmonary artery with aorta, so that the blood, rather than going to the lungs, it bypasses lungs and the blood is entering into the aorta. Here, what we should remember is Placenta acts as lungs, kidney and GI tract of the fetus. This is placenta. As we can see here, this is the wide umbilical vein. As you can see here, these two are the umbilical arteries and one umbilical vein, and umbilical vein is wider. It carries oxygenated blood. 70 to 80% is the oxygen content of the blood in the umbilical vein. Through umbilicus is it ascends up and it sends a very small branch which is called as a hepatic branch to the liver. But the major uh, content of the blood, major blood flow through this umbilical vein, it goes through ductus venosus and it enters into inferior vena cava. This is a oxygenated blood, red one, and blue one is a less oxygenated, which is coming from the lower part of the body, already going through the inferior vena cava, this current. Surprisingly, these two currents do not mix with each other, and the oxygenated current passes through the inferior vena cava into the right atrium. Through foramen ovale, it enters the left atrium, then from there to left ventricle. And this well oxygenated 70 to 80% oxygenated blood mainly supplies the vital organs of the fetus, such as fetal brain and the fetal heart. A small branch also goes to the pulmonary artery and drains oxygenated blood into the pulmonary artery. Now this less oxygenated blood, which is around 40% is the oxygen saturation in this less oxygenated blue one, it enters into the right atrium as well as the deoxygenated blood from the upper part of the body through superior vena cava also enters into the right atrium, and this less oxygenated blood passes from right ventricle and enters into pulmonary artery. So now pulmonary artery has a mixture of the well oxygenated and less oxygenated blood. This blood, rather than supplying the lungs, it enters into the ductus arteriosus, bypasses lungs, and it goes to the aorta. Through aorta, it is going to the common iliac and external and internal iliac. And from internal iliac, the two umbilical arteries are draining this blood back to the placenta. So umbilical arteries are the branches of the internal iliac arteries. And this less oxygenated blood goes to the placenta. It carries CO2 as well as waste material. And here there is a uteroplacental circulation, rich circulation is there, and exchange is there, so that waste products enter into maternal circulation. Nutrients from maternal blood enter into the fetal circulation as well as oxygen enters, and CO2 also goes to the maternal blood. So CO2 waste products from umbilical artery enter into the maternal circulation, whereas oxygen and nutrients from maternal circulation are entering into fetal. And again the umbilical vein is carrying the oxygenated blood. So this cycle keeps on repeating. It is mainly dependent on what we have till now seen is a invasion or remodeling of spiral arteries. If there is a remodeling, then there is this adequate uteroplacental blood flow is there, and adequacy of the uteroplacental circulation is there, and there is a good oxygen content in the fetal blood, and that is how it helps into the normal growth of the baby. This is a list of the vessels. We will see one by one later on all these, how these are the vessels which we are using. But diagrammatically, what you should always remember is ductus venosus. How you should remember? It is near umbilical vein. So vein. Whereas arteriosus is here near the pulmonary artery. So ductus pulmonary artery and ductus arteriosus. Whereas ductus vein, umbilical vein are in proximity to each other. What is Doppler effect is? This is a commonly used terminology, so we should at least know that much of a basic related to the physics of the Doppler. This is the transducer which is from where the sound waves are coming. When these sound waves they hit a moving object. They encounter a moving object in the body, such as blood in a blood vessel. These waves are getting reflected back. Now, these reflected waves have a changed frequency as compared to the original waves. And this change in the frequency is dependent on velocity of the moving object and direction of the moving object. In other words, velocity of the blood and direction of the blood flow. And that is how, because of this Doppler effect, what we can evaluate is we can evaluate the blood flowing in a blood vessel with the help of doing a Doppler. So Doppler effect it helps us to evaluate how much is the blood flow, how much is the velocity, what is the direction of blood flow. That can be evaluated because of this property of Doppler effect. There are two types of Doppler. One is continuous waveform and other is pulse waveform. What we need to understand is whatever in the fetal Doppler we are using pulse waveform, whereas continuous waveform is used in echo, where there are two crystals are used. One crystal is continuously sending the sound waves, other crystal is continuously capturing or recording the reflected waves. Whereas in pulse waveform, there is only one crystal. It sends the signal, pauses to record the reflected signal, and then sends the next signal. So it is like a pulse. Now the main difference is here we can identify individual vessel, and that is why it is pulse waveform is commonly used whenever we are doing a fetal. Now, why we use ratios to express Doppler results? Always we are using either a SD ratio or pulsatility index, resistance index. So, why there is always a ratio which helps us to uh, assess the Doppler velocimetry? It is because of what we can see here is this is the transducer and this is the vessel. Now these sound waves are making an angle with the direction of the flow. In this direction the flow is going, and this is an angle. This angle is also called as insulating angle or theta. Now if theta is 0 or near 0, there is no measurement error. But if it is more than especially 20 degrees, then there is a measurement error. Now here if transducer is here, and if the blood in a vessel is directly flowing towards or directly flowing away from transducer, then the angle theta is almost 0 and there is no measurement error. But in most of the vessels, such as uterine artery, umbilical artery, it is not possible to have this theta which is near 0. Only vessel where we can have a theta which is near 0 is middle cerebral artery. Remember, why we can measure peak systolic velocity only in middle cerebral artery, and we can't measure it in umbilical artery or uterine artery or ductus venosus. The reason is this, that in the middle cerebral artery blood is directly flowing towards transducer or directly flowing away from the transducer, so that the measurement error is not there. But in all other vessels, there is a possibility of measurement error, and to overcome this problem, whenever we use ratios, the theta comes in numerator as well as denominator, and it gets nullified. And that is the reason we are using ratios whenever we are interpreting this vessel blood flow by using the fetal Doppler velocimetry. These are the ratios. SD ratio is peak systolic velocity upon end diastolic velocity. It is usually expressed in percentile. Now here, as you can see, this is the peak systolic and this is the end diastolic. So peak systolic velocity divided by end diastolic velocity gives us the SD ratio. Resistance index is S minus D upon S. Pulsatility index is S minus D upon M, or average, mean or average. This mean or average is, we get it as with the help of computer. So it is computer generated mean or average. Resistance index and pulsatility index is usually expressed as plus minus standard deviation of the normal, plus minus SD of normal, whereas SD ratio is expressed as percentile. If we see the reports of the Doppler, what we observe is initially we used to get evaluation of the Doppler by using say, SD ratio. But now more and more sonologists are using pulsatility index to evaluate the Doppler velocimetry in fetal Doppler. So why we are preferring this pulsatility index over resistance index or SD ratio? Pulsatility index has a linear relationship with the blood flow velocity, as we can see here. On the other hand, this resistance index and SD ratio, they have a parabolic relationship with the blood flow velocity. So we have seen up till now how the spiral artery vasculature remodeling, if it doesn't take place, then how there is a placental insufficiency, which results in various problems. Then we have also seen the and not mainly the fetal circulation and the physics related to some of the important points related to physics related to fetal Doppler. Now we will start with the individual vessel, and the first vessel which we are going to see is the umbilical artery Doppler velocimetry. It is the most studied fetal vessel. First vessel, if you see in the historical aspect, it is the most studied one and giving us a clarity related to the fetal Doppler. First to show, it is the first vessel which shows abnormality in small for gestational age babies because of the placental dysfunction. Now HGA, that is small for gestational age, is in majority of the cases it can be because of placental dysfunction, but there are other reasons also of HGA, such as there can be a fetal infection, there can be a gross congenital malformed baby, chromosomally abnormal baby. But if it is because of placental dysfunction or chronic placental insufficiency, then the first vessel which shows abnormality is umbilical artery. As we have already seen, two umbilical arteries are branches of internal iliac arteries. These umbilical arteries are carrying deoxygenated blood from fetus to the placenta. What is a unique feature is this artery shows a continuous forward flow normally throughout the cardiac cycle. That means during systole as well as during diastole, there is a continuous forward flow through the umbilical arteries normally. Short form, which is used in standard textbooks as well as in the literature for umbilical artery, is UA, whereas for uterine artery it is capital U, small t and capital A. That I think we should remember this. Now in a diastolic flow, normally in the umbilical artery, it increases with advancing gestational age because of reduced placental impedance. Impedance means resistance, as well as increasing cardiac output of the baby. So as the gestational age advances, this placental barrier becomes thinner and thinner, and that leads to the reduced placental resistance normally. And normally what we expect is even during systole there is a good circulation, but during diastole also what we expect is a increasing diastolic flow as the gestational age increases. Now always another thing is, now this is umbilical cord and red one is the vein, whereas blue are the two umbilical arteries which are present in the umbilical cord. And these umbilical arteries, as we have already seen, are carrying the deoxygenated blood from fetus to the placenta. It has two ends, one is a fetal end and another is a placental end. Normally what is seen is this diastolic flow is lesser at the fetal end as compared to the diastolic flow at the placental end. So I want you all to remember that this yellow one. So where is the less diastolic flow is less at which end? It is less at the fetal end of the umbilical arteries. Usually umbilical artery Doppler is usually done in a free loop of cord, like here have what we can see in this diagram. Like a loop is selected and in that the umbilical artery velocimetry, Doppler velocimetry is studied. But if it is abnormal, then for subsequent measurements, usually fetal end is preferred, because now we need to detect at the earliest whether the abnormality is increasing in severity, whether reduced diastolic flow is getting converted to absent diastolic flow, or it is getting even further getting worsened to reverse diastolic flow. So for that, whenever it is abnormality, then remember that what the area point nearer the fetal end is selected for the subsequent Doppler study of the umbilical artery. Normal values of SD ratio in umbilical artery. This table shows we can remember it as at 20 weeks it should be, after 20 weeks it should be more than less than 4, after 30 weeks it should be less than 3, and at term it is approximately around 2. Now this is just to remember, or whenever we see a report, just it is a gross one, but remember that it is available, the values are available with the sonologist for each gestational age, and what we need to be careful is to calculate a gestational age correctly, and accordingly there is a value which is which will be different for say at 32 weeks SD ratio, there will be a particular value, whereas at 33 weeks it will be different, at 34 it will be different. So from week to week there is a chart is available, but this is just to show the grossly what we expect is how with a reducing placental resistance, how the SD ratio falls as the denominator is diastolic flow, and as the denominator is increasing, what we expect in a normal pregnancy is as gestational age advances, there is a reduction in the SD ratio in the umbilical artery. Whenever SD ratio is more than 95th percentile for that gestational age, then we say that it is abnormal. This is a normal SD ratio, peak systolic upon end diastolic. This is the blood flowing in the systole during systole, and this is the blood flow in diastole. Now, comparatively, as you can appreciate here, in the diastole, blood is still flowing, but it is less. Blood flow or blood velocity has reduced. So here what we say is, what will happen to the ratio is SD ratio will be more than 95th percentile for that gestational age, and in other words there is a decreased diastolic flow. Decreased diastolic flow will lead to increase in SD ratio. Further deterioration suppose happens in the placental resistance, it is increasing more and more. What will happen is there will be absence of diastolic flow, absent diastolic flow. And worst scenario is where there will be a reversal of the flow, reverse diastolic flow. And the short form which is used for these two conditions is this absent or reversal of end diastolic velocity. And whenever it is present, either absent or it is reverse, it indicates that more than 70% of the placental vessels are already obliterated. So this is serious, absent diastolic or reverse diastolic flow. Umbilical artery Doppler is the primary surveillance tool in small for gestational age fetuses to decide. Mainly, it helps us to decide timing of termination of pregnancy whenever there is a preterm HGA, preterm small for gestational age pregnancy. Because here we know that there is a risk of going for a if we terminate too early, there is a risk of having a perinatal mortality because of prematurity itself. And if we take a decision too late, there is a risk of baby being born either hypoxic or even worst is sometimes there can be even a stillbirth. So we want to strike a correct balance and have a correct timing, best possible timing for the termination of pregnancy whenever there is a preterm HCA. And here umbilical artery Doppler is, it helps us, and it is that is called as a, that is why it is called as a primary surveillance tool. If it is normal in a patient diagnosed case of HGA, then one should repeat fetal Doppler every 15 days. If it is abnormal, or if fetal growth restriction is severe, then more frequent testing is indicated, such as if there is a reduced end diastolic flow where the pulsatility index or resistance index is more than +2 standard deviation of normal, then in these cases we need to repeat it every 3 to 4 days or bi-weekly. Absent or reverse diastolic end diastolic flow, as we have already seen, it is a severe. It indicates more than 70% placental vessels being obliterated. So here, if it is a preterm, very preterm, early preterm HGA, and we need to gain some precious days, and we will need to uh, take the pregnancy, say it is at 24 weeks, we need to take it to 26 weeks. In these cases, one needs to repeat it on daily basis. What is the role of umbilical artery Doppler? It is strongly recommended in management of fetal growth restriction. We have already seen that it helps in uh, deciding the timing of termination, and the studies have proven that it improves the outcome in fetal growth restriction. Perinatal outcome definitely improves whenever we are using umbilical artery Doppler in patients of fetal growth restriction. It is not recommended as a screening test for fetal growth restriction. It doesn't help. If you do as a routine umbilical artery Doppler, it doesn't give, it is not a predictive test for fetal growth restriction. Whenever we get an abnormal umbilical artery Doppler, it is an indication to rule out aneuploidy or congenital malformations in the baby. Now, why there is a umbilical artery Doppler is abnormal in fetal growth restriction, as we can see in this diagram. What is happening here is whenever there is a placental resistance, what it leads to is an increase in afterload. That means over the heart. From the aorta, the umbilical arteries are draining to the placenta. But because placental resistance is present, what will happen is there will be a afterload. For the second step will be, so because of this afterload, there will be changes in the umbilical artery. Diastolic flow will keep on reducing because of this increasing resistance. Then next is there is a redistribution of the blood flow, and more blood flows to the brain and heart, and that is how there are changes. Second vessel which gets affected is middle cerebral artery. And what is happening with the worsening situation is the afterload increases even on the right side of the heart, and that is when there is a last vessel which shows abnormality in a patient of small for gestational age fetal growth restriction. Severe variety is there will be changes in ductus venosus and umbilical vein flow. Both will be showing abnormal Doppler velocity. So first vessel which gets affected is umbilical artery. Second vessel is middle cerebral artery in a patient of HGA with worsening hypoxemia. There is cardiac dysfunction, and that leads to changes in the ductus venosus Doppler. Second vessel is middle cerebral artery. It is a branch of internal carotid artery. It is selected because it is the most accessible, and it is sensitive to blood viscosity and oxygen saturation changes. Here, as we have already seen, theta or insinuating angle is near zero. It is definitely less than 30 degrees. As vessel, it is the word which is used, terminology which is used is vessel comes head on towards the transducer. So that is why it is either the blood flow should be directly coming towards or directly going away. Then there is a theta is almost zero or near zero, and that is the reason why in this vessel we always express it as peak systolic velocity. Middle cerebral artery PASV. That is how we see for that, and the reason is because it is this measuring error is less because the vessel it is possible to adjust the angle, so the insonating angle, so that it is less than 20 degrees. This is the circle of Willis, which is formed by anterior cerebral, middle cerebral, and posterior cerebral arteries. Here, that is how we identify it at the base of the skull. Select it and study the fetal Doppler velocimeter. Middle cerebral artery Doppler it has a major role in detection of fetal anemia. It has almost replaced amniocentesis completely now because it is a non-invasive test. It has a major role in management of alloimmunized pregnancy, RH incompatibility, MCA PSV, that is middle cerebral artery, peak systolic velocity, increases in fetal anemia because of the increased cardiac output and reduction in blood viscosity. So as a response to the anemia, cardiac output increases and there is a reduction in blood viscosity. These are the two reasons why there is increase in peak systolic velocity. Whenever peak systolic velocity is more than 1.5 multiples of median, it indicates moderate to severe fetal anemia necessitating intrauterine blood transfusion. So remember this figure, more than 1.5 MOM, that is multiples of median. In patients, whenever there is a fetal anemia, serial middle cerebral artery measurements are to be done. And if the value is between 1 to 1.5 MOM, then weekly testing is indicated. What we should be cautious is whenever gestational age goes above 35 weeks, then false positive results might be there because naturally also there is increase in cardiac output at this gestational age, and there we should be more careful while interpreting the MCA PSV after 35 weeks of pregnancy. Now, this is an example mainly to explain what do you mean by multiples of median. Now, mean is median, I'm sorry, it should be median. Median is the value at the middle or center of all the numbers. So what is this MOM? So we are using multiples of median. Median is, as we have already, you must be remembering from your statistics days that we have mean, median and mode. So median is the number which comes at the center. On one part are the numbers which are greater, at other part are the other numbers which are less, and it is exactly at the midway. Now, if median of MCA PSV, normally if at 34 weeks it should be 35 centimeter per second. But here, as we can see, it is 70. This peak systolic velocity here is going up to 70 centimeters per second. That means this patient has her MOM is 2. It is she has 2 MOM or 2 multiples of median, and whenever it is more than 1.5, as we have already seen that it is a feature of moderate to severe anemia. That means this baby has moderate to severe fetal anemia. Now, one question for all the postgraduates who are listening this lecture is, which is the other investigation in the obstetrics where we use this unit to express the results, unit of MOM, multiples of median. And I hope that I get answers in the comment box to this question. I will be repeating the question, which is the other investigation where we are using this unit of multiples of median in obstetrics. Now, what is the place of this middle cerebral artery Doppler in small for gestational age? It is used as an adjunct, additional investigation to umbilical artery Doppler. As we have already seen, the main surveillance tool in SGA is umbilical artery Doppler. Hypoxemia, whenever there is a hypoxemia in the fetus, it leads to redistribution of blood. We have already seen that. There is more blood which is flowing to the fetal brain, heart and adrenals whenever there is a fetal hypoxemia. Increased flow in the middle cerebral artery is traditionally known as brain sparing effect, but unfortunately, it is not sparing the fetus. It is a misnomer. as there is, on the other hand, there is increase in perinatal mortality. Cerebroplacental ratio is the ratio which is used to see how much is the increase in the blood flow to the brain. It is as MCA pulsatility index divided by umbilical artery pulsatility index. How you remember it is cerebroplacental ratio, CPR. So first is cerebro, so you have at the numerator MCA, middle cerebral artery. Second is placental, so in the denominator you have umbilical artery. Whenever this ratio is more than 1, it is associated with adverse perinatal outcome. What we need to remember is this middle cerebral artery pulsatility index is not giving us a clear picture, and it is not helping much in deciding the timing of termination in patients of small for gestational age. Third vessel is ductus venosus. It shunts oxygenated blood from uterine vein to directly to inferior vena cava rather than going to the liver. It is bypassing liver. It is identified at near the fetal diaphragm. It has a biphasic waveform. First peak indicates ventricular systole. Second peak indicates ventricular diastolic filling. And then there is a fog, nadir. And this nadir is because of the atrial contraction. This nadir is called as a wave. Ductus venosus abnormality is seen whenever there is a severe fetal growth restriction and severe hypoxemia. It is because of afterload to, we have already seen, it is just to revise that it is because of the afterload to the right side of the heart, which leads to the myometrial dysfunction, cardiac dysfunction, and that cardiac dysfunction is leading to the abnormality. Whenever there is a reduced, absent, or reversed A wave is because of the atrial contraction. But if there is a reduced, absent, or reversed A wave, it indicates cardiac dysfunction. Reverse A wave with pulsatile umbilical vein waveform. Whenever there is a reversal, now whenever it is reduced or absent, it is not. These are abnormalities, but the most severe is reversed A wave. And this reverse A wave is seen sometimes with pulsatile umbilical vein waveform. Now, umbilical vein is getting affected only in very severe cases of hypoxemia, where there is a reversed A wave and the blood is flowing in a pulsatile manner in umbilical vein because of the increase afterload to the right side of the heart and because of the cardiac dysfunction. Now, using the ductus venosus Doppler doesn't improve the prognosis in patients of fetal growth restriction, because whenever it is present, it is usually the baby is severely hypoxemic. And at present, it is not recommended in routine management of fetal growth restriction. This is normal. First peak indicates the ventricular systole. Second peak indicates the ventricular diastolic filling. Whereas this is the nadir, or this is the atrial contraction leading to the A wave. This is the normal waveform of the ductus venosus. This is reduced A as compared to here. The blood flow in the during atrial contraction is less. Or there can be absent wave A wave, or there can be reverse A wave. Reverse A wave can be associated with umbilical vein pulsatile waveform. Here, as you can see, it is a pulsatile waveform. This is umbilical artery which is showing absent in diastolic velocity. Here we can't rule out whether it is absent or reverse because it is getting superimposed by this umbilical vein pulsatile waveform. So umbilical vein pulsatile waveform is usually it goes along with a reversed A wave. Whenever there is a reversal of the A wave, atrial contraction, on the other hand, there is a reversal of blood flow. That time it is seen that there is a pulsatility waveform in the umbilical vein. Indications for ductus venosus are for staging twin-to-twin transfusion syndrome. As here I have shown you the TTTS staging. because we are already, if we say, we should know. If you say, give any, suppose you are asked what are the indications of ductus venosus, and you say that it is used for staging of twin to twin transfusion syndrome, you will be asked what is this staging. So stage 1 is when the deep vertical pocket of the amniotic cavity shows in one fetus more than 8 centimeters, in the other fetus less than 2 centimeters. Stage 2 is when the donor fetal bladder is not seen for more than 60 minutes. Stage 3 showing Doppler abnormality either in the umbilical artery, ductus venosus, or even umbilical vein. Stage 4 is presence of hydrox fetalis in one or both the babies. And last stage 5 is when there is a intrauterine death in one or both the fetuses. Whenever there is a congenital heart defect, then to monitor that fetus, ductus venosus Doppler is used. That is, this is the second indication. Third is if the baby has, fetus has SVT, supraventricular tachycardia, and then in these cases we give antiarrhythmic drugs to the mother, such as digoxin. So before and after treatment monitoring is done in these cases. So it has a definite place. Ductus venosus has a definite place whenever the baby has, fetus has cardiac dysfunction. That you remember that it is the investigation of choice whenever there is a cardiac dysfunction, either because of this twin to twin transfusion syndrome or congenital heart defects, or we have already seen that whenever there is a severe degree of fetal hypoxemia or small for gestational age fetus, which is a severe, which is affected in a severe manner. Absent is also used as a minor aneuploidy soft marker in the first trimester. So this is latest. As we already know that there are aneuploidy markers in the first trimester such as nuchal translucency or beta SCG or PAPPA. Along with that, there are some additional markers which are called as soft markers, minor markers. And this ductus venosus shows absence or reversal of the AVF. This is also considered as one of the minor aneuploidy soft marker. Second question for postgraduates is, what are the other minor aneuploidy soft markers used in first trimester? I hope that I get uh, comments for these two questions. First question already I had ask you about MOM, investigation where we use the multiple of million. Second question is, what are the other soft markers apart from ductus venosus Doppler, which for the aneuploidy screening in the first trimester? What are the other soft markers? Normally, what is happening is 40% of the cardiac output in the baby goes to the placenta to umbilical arteries. 40% of the cardiac output, it is going to the placenta. But whenever there is a placental insufficiency, there is increased resistance to the blood flowing through the umbilical arteries. That increases the afterload to the left side. Then a stage comes when even the afterload to the right side also is increases, and that leads to cardiac dysfunction. This cardiac dysfunction is affecting the ventricular as well as atrial contraction, and it affects this inferior vena cava blood entering into the right atrium, and that is how we get the ductus venosus abnormality whenever there is a cardiac dysfunction. Next vessel is uterine artery. Uterine artery, as I have already said, that whenever we want to write a short form, umbilical artery we write UA capital, whereas for uterine artery we write capital U, small t, and capital A. As here you can see, it has a high diastolic flow and a turbulent diastolic flow. As compared to the other vessels, this height of diastole is more here, as you can appreciate. So uterine artery, during diastole also, the blood which is flowing through the uterine vessel during pregnancy is significant. Testing of uterine artery Doppler is usually done at 22 to 24 weeks. Uterine artery helps us to understand how the placental development has taken place and how whether the degree of remodeling of spiral arterioles or arteries is normal or not. That is why we do the testing at 22 to 24 weeks, because normally we know that the secondary invasion is getting completed by 24 to 26 weeks of pregnancy. Now this is normal. Here you can appreciate that there is a depression and then again increased blood flow. This is called as diastolic notch. This is the diastolic notch. Now if this type of a picture is seen before 22 to 24 weeks, it is normal. But if there is a persistence of diastolic notch and greater resistance to the flow in the uterine artery after 24 weeks, it indicates poor placental invasion. So uterine artery is mainly helping us to know how the placental development has taken place and how the remodeling of spiral arteries has taken place. This is also whenever there is a persistence of diastolic notch or there is a greater resistance to the flow after 24 weeks in the uterine artery, it is associated with increased risk of hypertensive disorders in pregnancy, fetal growth restriction, and even if it is seen in a chronic hypertension, risk of superimposed preeclampsia is greater. What are the current recommendations for the use of uterine artery Doppler? Now, placental resistance reduces after complete placental formation by 20 to 24 weeks. Increase SD ratio or pulsatility index or resistance index in the uterine artery at 22 to 24 weeks indicates high resistance. So what we expect is by 22 to 24 weeks there is a complete placental formation and there should be a decrease in the resistance. But predictive value for this use of uterine artery Doppler is more for fetal growth restriction as compared to hypertensive disorders in pregnancy. Presently, use of uterine artery Doppler is not recommended as a screening test either for high risk group or low risk group pregnancies for these two conditions, fetal growth restriction or even for hypertension in pregnancy. This is a recommendation by Society for Maternal Fetal Medicine 2020. Why it is not recommended is because of its poor predictive value. It has a possible use if it is done at 22 to 24 weeks of pregnancy with a previous stillbirth. It has some doubtful, but it has a possibility that it can be helpful in these patients with a previous history of a stillborn baby. But otherwise, in other low or high risk cases, presently it is not recommended as a screening test. Ductus arteriosus Doppler. It is primarily used to monitor fetuses exposed to either indomethacin or other non-steroidal anti-inflammatory drugs. Indomethacin causes ductus arteriosus constriction or closure if used in third trimester either as a tocolytic or in patients with hydramnios. Increased blood flow to pulmonary artery because of this ductus arteriosus constriction. What will happen is blood will be flowing more towards the lung through the pulmonary artery, but it leads to reactive pulmonary hypertrophy and primary pulmonary hypertension in the baby, fetal primary pulmonary hypertension. This risk is more if the drug is used for more than 72 hours. So it is almost the risk is more by 12 times more risk if we use indomethacin or other NSAIDs for more than 72 hours. Fortunately, these changes are reversible. That means if the drug is stopped and you monitor the baby, we can see that this constriction or closure goes off and the blood flows normally through the ductus arteriosus. Low-dose aspirin, whenever we are using it with a dose of less than or equal to 100 milligram, doesn't carry this risk of ductus arteriosus constriction or closure. It is associated with high-dose aspirin only. Now to summarize, vessels investigated in fetal Doppler with information gained. Whenever we are doing umbilical artery Doppler, what we are assessing is Placental function. How is the placenta? Whenever there is a placental dysfunction, increased placental resistance, chronic placental insufficiency, the first vessel which is getting affected is umbilical artery. We use middle cerebral artery to assess fetal response to placental dysfunction. So whenever there is a placental dysfunction, there is a redistribution of blood flow. More blood is flowing to the brain, and that is why whenever we do MCA Doppler, what we are assessing here is a fetal response to placental dysfunction or hypoxia, and also we are assessing it to know the diagnosed fetal anemia. Ductus venosus is mainly its place is for aneuploidy screening and inpatient fetal cardiac dysfunction. Whenever there is a fetal cardiac dysfunction, it has a specific place. Uterine artery helps us to assess placental development, whether the invasion, primary, secondary invasion has taken place normally or not. Whereas ductus arteriosus is mainly used to monitor the effect of non-steroidal anti-inflammatory drugs, especially indomethacin. These are the indications we have already seen. Just to summarize that again, diagnosed cases of small for gestational age babies, alloimmunized pregnancy RH incompatibility, TTTS staging, twin to twin transfusion syndrome staging, first trimester aneuploidy screening, fetal anemia might be of non-immune cause, such as in fetal infection. In these cases also, whatever is the reason for fetal anemia, MCA Doppler will help us in diagnosis as well as to know whether the fetal condition is worsening. If baby has congenital heart disease or supraventricular tachycardia, ductus venosus Doppler will help us. Fetal monitoring in use of NSAID in third trimester especially. Doubtful places for screening for fetal growth restriction, hypertension in pregnancy, or to predict placental dysfunction. It has a doubtful place at present for this indication. And previous history of stillbirth, there is a possibility that the uterine artery Doppler might be helpful. This slide I have included mainly for the postgraduate students so that you practice drawing these line diagrams related to fetal Doppler velocimetry. Umbilical artery, how you draw it is you draw baseline first and you keep a distance and then draw the systolic and diastolic waveform so that it indicates that, and then just fill up the this uh, portion with the lines so that it indicates that blood is flowing during systole. Though the velocity is less, it is also flowing during the diastole normally. When you want to show the reduced diastolic flow or increase in SD ratio, what you need to do is you draw the normal one and show that diastolic blood flow is nearer the baseline. That means there is a reduction in diastolic flow. This is how you draw the absent diastolic flow and the reverse diastolic flow. So practice drawing it at least once or twice so that it comes naturally to you whenever you will be solving the theory paper. This is middle cerebral artery, which shows the peak systolic velocity so that you draw it like that. Systolic velocity is mainly measured so that systole you focus more on the high systolic blood flow. Ductus venosus has a biphasic waveform where there is a one first peak is with the ventricular systole. Second peak is with the diastolic refilling of the ventricle, and we have a third nadir which is called as the A wave. It is called as A wave. It is because of the atrial. It indicates atrial contraction. So the practice drawing it also, the shape of the ductus venosus differs. It has a biphasic curve. Uterine artery, on the other hand, be careful whenever we are drawing for the uterine artery that it has a high diastolic flow. That means above the baseline. In diastole, it is at a higher level because the systolic blood flow is high, as well as during pregnancy, diastolic blood flow is also high in uterine artery. If there is a depression just after the systole, then we call it as a diastolic notch. So practice even drawing this diastolic notch also. Ductus arteriosus is what is happening is whenever this is normal, that means it has a systolic peak systolic as well as peak diastolic velocity. Diastole also has a peak and then it comes down. and then it is an end diastolic flow. Whenever there is a constriction, the systolic velocity increases as well as diastolic velocity increases. Because of the obstruction to the flow, there is more velocity passing through the. So remember that though we consider that constriction will lead to reduction in blood flow, amount of blood flowing reduces, but what is increasing is the velocity. The velocity of the blood flow is more. That is why we get a higher S as well as we get a higher D. And once the patient's suppose patient is taking indomethacin, you stop it, then it goes back to the same, that is normal. There will be, it is reversible so that it returns back to the normal. Thank you so much. Hope that your ideas related to the fetal Doppler, its use in pregnancy, this lecture helps you to clear some of the ideas. And I hope that you will be answering the questions which I have asked you. Thank you once again.